everyone. This is going to get this event underway shortly. Thank you very much. So my name is Richard Jones. I'm editorial director of Devex and delighted to welcome you all to this special Devex at UNGA 79 event. Thank you for joining us for this important discussion, ensuring cancer care for all, tackling persistent health inequities. So it's a real privilege to be here with all of you in the room here in New York, and to our online viewers around the world, welcome. Now, while the world has seen remarkable advances in cancer survival rates, these improvements have not been shared equally. Around the globe, millions of people continue to face immense barriers in cancer prevention, diagnosis, and treatment. Disparities based on income, race, geography, and other social determinants of health persist, often determining who survives and who does not. In the US alone, this year marks a troubling milestone. For the first time, 2 million new cancer cases will be diagnosed. And while cancer deaths have decreased overall, the burden remains unevenly distributed. These inequities are not just limited to the US, but are mirrored across other high-income country contexts. This inequality is driven by social determinants of health, factors like income, education, geographic location, which influence access to cancer prevention and treatment. The tragic reality is that these disparities are largely preventable. Through collective, sustained action, we can ensure all of us within the global development and global health communities that everyone has a fair chance at survival, no matter where they live or who they are. So today's event, hosted in partnership with MSD, known as Merck in the US and Canada, together with the American Cancer Society, is going to focus on how we can make this vision a reality. We'll hear from oncology experts, advocates, healthcare providers, and cancer survivors about the barriers that still exist, and just as importantly, the innovative solutions that are being developed to overcome them. So without further ado, let's get started. I'd like to welcome to the stage my colleague Meg Richardson, Chief of Staff at Devex, together with her first guests. A big round of applause, please.
Thank you, Richard. And thank you all for being here today for this important topic, a topic that for so many of us in the room really does hit home. I'd like to start with Nefertiri here, who is a 3-time cancer survivor, a tireless advocate, a nurse. Nefertiri, can you kind of set the scene for us? Tell us a little bit about your work with outreach into the Black communities. What successes are you seeing? What challenges are you still facing?
Yeah, thank you. Yes, I am the Black Women's Outreach, Director of Black Women's Outreach, also known as AfroShare, at Share Cancer Support. And so what we do as the outreach team, we go in the communities of color, in particular the Black community, and we offer education information about breast and GYN cancers, such as the one that we serve, uterine, ovarian, and cervical cancer. We also share, do presentations by sharing our personal stories with GYN cancer or breast cancer, along with, taking questions, asking questions, helping people or the community formulate questions to their doctors, because lots of times when we receive these diagnoses or at an appointment, we don't know what questions to ask or even if we should ask questions. So we do encourage people to ask questions along with advocating for themselves, teaching people how to be their best advocate. Some of the questions we have or challenges is access to care, also the disparities when it comes to not being dismissed and not, taking our symptoms or whatever, issues or discomfort that we're having aren't being taken seriously.
Right. We know that women's pain traditionally has been downplayed by medical practitioners.
Absolutely.
Natasha, I'd love to hear from you. What we know that financial barriers, lack of access, this disproportionately impacts different communities. Tell us about your work in screenings and what you are seeing.
Yeah, so at the American Cancer Society, we work through partnerships, right? And so that's what we're here today to do and talk about. We can't do it alone, so we definitely have our staff that are dedicated to our health system partners based on the population and the communities that they serve. And so we work with our health system partners, our cancer centers, our state-based systems. We also work with our federal qualified health centers and our community-based health centers as well, too. The goal really is to increase screening. And so we really work with our partners to identify gaps, screening barriers, access to care issues that we just talked about, and really identify a plan and policy changes that can really be implemented, evidence-based policies that could be implemented at the practice level.
And what do you wish people in the room knew about supporting patient navigation?
Yeah, patient navigation is really key. Our navigators, the navigators we see out in our healthcare systems, they walk through the cancer journey from the early detection, from the screening. So we have screening navigators fully going through their cancer journey, follow-up procedures, making sure patients do not fall through the cracks. And then we have navigators that are oncology navigators. So the American Cancer Society is really trying to enhance our navigation services with our partners. We have a new app called ACS Cares, and it really is a peer support app where community volunteers are matched with a patient and they can talk virtually with our patients and really give them an opportunity to know that they're not alone in their cancer journey.
Josette, you have you've spent a lot of your career at MSD thinking through some of the solutions to problems like this. Can you tell us a little bit about how healthcare professionals, manufacturers can ensure access to this care?
Sure. Maybe just for starters, I think it's important to acknowledge that in high-income countries, disparities are real, inequities are occurring, and it's occurring across the board. It's not just racial inequities. It could be urban, rural divide initiated inequities. It could be gender-based inequities. So it could cut across a number of different variables. So I'm very happy that we're leaning into this topic and talking about this. But as far as just the various actors across the ecosystem, we all bring different capabilities and solutions to bear to support patients across the cancer continuum. And it's not going to take one stakeholder alone to make impact at the patient, at the community, and certainly at the population health level. So when I think about healthcare providers, for example, wow, healthcare providers are sitting on really an amazing array of clinical data that can really start to pinpoint why disparities are existing, who's not getting access to certain treatments, who's not getting access to screenings, why is early detection so low in certain communities. They're sitting on that data, and they're now able to do risk-based algorithms to anticipate, right, risk for certain populations, risk for certain patients. They're now able to do social determinants of health screening. So being able to see providers leverage these capabilities to now support patients throughout their journey, seeing them also engage with community-based organizations has been another, I think, very critical piece to this puzzle, because community-based organizations know patients and communities the best. They're able to provide wraparound services. So I think providers are leaning on these types of solutions. When I think about payers as well, they are bridging claims and clinical data, doing the same as well to understand hotspots. They're leveraging virtual navigators, virtual care coordinators. They're experimenting with reimbursing community-based organizations. So I think payers need to continue to lean into that. Certainly from a manufacturer perspective, we also feel committed to addressing inequities. I can use us, for example, Merck, MSD, where we are looking at, the standard of care and where you've seen lack of adherence to standard of care, so that we are beginning to hone in on where the disparities exist in terms of access to certain types of treatments. We are also certainly very committed to partnerships, like the partnership we have with the American Cancer Society, and how we can support patients through that patient journey, through that continuum, thinking about access and how we can also work with providers to support broader access to care services. So I think across the board, clinical trials, I shouldn't fail to mention clinical trials and what we can do to really support broader, really retention, to clinical trials and making sure that they're representative of the communities that we aim to serve. So it takes a very holistic, collaborative approach across all of the variety of stakeholders in the ecosystem.
And advocacy and communicating about all of those solutions is such a huge part of the solution. Nefertiri, I'd love to come back to you. Can you tell us a little bit about your own personal journey into advocacy, and what are some of the learnings that you have now that help to improve that you've seen help to improve the lives of these issues?
Well, my journey began in 2013 when I was first diagnosed at a young age, the age of 33, with endometrial cancer. And just, I had one of the number one symptoms of endometrial cancer, which was bleeding, and bleeding outside of my regular menstrual cycle. And when I did talk to a doctor about it at an ER, which is, I didn't go there to be diagnosed because I didn't know what was going on. I didn't know I had cancer, but I was dismissed due to, a few different reasons that I believe. But once I did, once I was dismissed and advocated for myself, I just felt like there's so many different women, this is happening to. They go undiagnosed, misdiagnosed. I can't be the only one. And unfortunately, I'm not the only one. So that is what, I was just driven from that moment to get into, to start talking, speaking up about this and finding others, connecting with other people, because lots of time we also live in isolation. We don't know that there's others. And I think support is also key in survivorship or thriving and having a good quality of life. So that was one of the things that I learned, uh, finding and putting together a supportive network.
We talked a little bit earlier about how lonely it can be.
So many of us fall into isolation because we don't tell our families, we don't talk to anyone, we're afraid, we don't know what's going on. And then you've been dismissed or by a doctor, and even oftentimes made to feel like the diagnosis is your fault. So those are, reasons, some of the reasons for isolation. But I just find it to be very important to, speak up about it because it can help someone else. And that's my goal, is to help and inspire other people.
Natasha, I'd love to, in the last few minutes, I'd love to hear a little bit about the Get Screened initiative, and that is such a huge part of ensuring that you aren't just getting misdiagnosed, that we are realizing. Can you tell us a little bit about that?
So our American Cancer Society Get Screened campaign was really in response to the pandemic. We saw that, screening procedures were elective, and so folks were made to postpone or cancel their procedures. And if you were already late for your screening schedule, we saw that there was an urgency, a real urgency to get individuals back on their screening schedule, because we know late stage screening leads to late stage diagnosis, and we know what that means. And so we really did a multi-pronged approach. It was a media campaign, public awareness campaign, working with our partners like like MSD, providing many grants to our corporate and our community health centers, and really looking at how we can coalition building, right? And bringing our stakeholders together to prioritize how we bring those screening rates back up.
In the last few minutes, Josette, and I'd love to hear from Nefertiri as well. We're here at UNGA 79. There are policymakers tuning in. We have people in the room who are thinking through partnerships and how to support. What are you hoping that everyone takes away from this conversation?
Maybe two quick thoughts. The first is around really understanding what we're aspiring to achieve from an impact standpoint. So I think a lot of times we orient ourselves towards process measures. How many, screening services were provided, how many diagnostics were given. But I think we now need to get to a place where we understand, did a patient really complete a care pathway? Was there timeliness in diagnosis, right? Was there linkage to care? So I think really upping the ante in terms of how we're defining impact at the patient level. And then the second piece I would say is thinking about the entirety of the continuum. We can't solve for one, we can't solve for screening, we have to also solve for early detection. We also have to solve for access to treatment. So I think really being able to bridge all the steps that are needed to solve for that is another really critical piece that we could all really impact.
Natasha, any final call to action?
Screening saves lives. So make it a priority. Everything, integrate screening priorities in your policy, in your barriers, looking at the barriers within your practice. And how do we drive more people to screening and make it customized to your patients, meet the need of your community and the patients. It is not one size fit all.
Nefertiri, call to action for our audience.
Yes, I say listen to your patients. If you are a medical provider, I would say, thank you to the advocacy groups for bringing that supportive network together, and education. Educate yourself on the type of GYN cancers. Everyone knows about breast cancer, but GYN cancer seems to be, disproportionate and underserved. So I would say education as well. Yeah.
Thank you so much for taking the time to be here to talk about this really important topic. And can I get a round of applause for this amazing panel? And now I'd like to invite my colleague, our managing editor at Devex, Anna Gavel, to the stage.
And I'd like to invite my panelists as well to the stage. Well, thank you, Meg. Thank you, everyone. I'm excited to be continuing this fascinating and, as Meg said, important conversation on ensuring cancer care for all. We're going to be digging a bit deeper into persistent health inequities across the cancer care continuum. Just a quick note, we will have time for a Q&A at the end of this panel discussion, so please put your thinking caps on, and we hope you can participate in the discussion at the end. But first off, let's go ahead and introduce our panelists. I have Dr. Helen Cappuccino. Yep. Hard to forget that last name. Dr. Cappuccino is an assistant professor at the Roswell Park Comprehensive Cancer Center at the University of Buffalo and the University of Rochester. Welcome. And we have Dr. Teresa Wicklund Gillespie, who is the Looney Family Professor of Cancer Research at Emory University School of Medicine. Dr. Timothy Rebeck, who is the Vincent Gregory Professor of Cancer Prevention Epidemiology at the Harvard School of Public Health, and Dr. Annalise Rodriguez, who is Associate Professor, Director of Neurosurgical Oncology, and Vice Chair of Research at the Neurosurgery Department at the University of Arkansas for Medical Services. So thank you, everyone, for being here. Timothy, actually, let's go ahead and start with you. Your research on men of African descent and carcinoma of prostate evaluates risk factors for prostate cancer with a focus on genetic markers of causes and outcomes. Can you tell us more about the main findings of your work and how that should inform changes to policy and care delivery?
Well, we've been doing this work in Africa, across Africa, and in the United States for 20 years now. And we've learned a few things. I guess the things that I'd like to mention are things that are probably not only relevant to prostate cancer, but are lessons that for all cancer. And the first thing is that disparities, inequities exist at all phases of the cancer continuum, from very early risk and predisposition through to the advancement, the development of cancer, diagnosis, treatment, survivorship. There are disparities everywhere along this continuum, but the causes of those disparities differ. And so if you're thinking about how to intervene on a disparity, eliminate a disparity, the solutions to that problem are not the same. If you're trying to talk about risk of developing disease or mitigating progression from pre-neoplasia to invasive cancer, et cetera, the solutions are probably unique. both to the cancer, to the population, as well as to where you are in the cancer continuum. And so part of that knowledge, that understanding, has led us to really appreciate the importance of catching it early, going early into primary prevention, early detection. And we notice that the disparities increase as the cancer continuum advances. So the disparities in prostate cancer, but most other cancers too, are the most profound in mortality, in survivorship. They're much smaller in risk and in progression from pre-neoplastic early disease. So if you're thinking about trying to mitigate or eliminate disparities, it's really important that you start that process very early and don't only try to treat your way out of the disparity problem. This is sometimes, in many cases, at least in prostate cancer, probably too late then.
Helen, broader question, why is it so important to work on creating a more diverse healthcare workforce to be able to tackle these persistent health inequities and provide better healthcare to underrepresented groups? Can you tell us a little bit more about the work that you do in this area?
Sure. I'm also, in addition to my cancer care work, involved with medical school and helping to select new classes of doctors as they come in. And nationally, there's a real move towards a more holistic evaluation of applicants to medical school. And the goal is not to focus only on numerical metrics, but to look at people who bring special perspective to delivery of medical care. And the goal and our aspiration is to create classes of doctors who look like the communities that they'll serve. People who look the same, worship the same gods, love the same people, so that when people come in for care, when patients come to receive care, they're dealing with a doctor who can be sensitive to what their particular interests, concerns, and beliefs are, and be more sensitive to it. And in the absence of being able to do that on a reliable basis, I think it's really important that we turn and look at ourselves for unconscious and implicit bias, because as was so mentioned previously by Josette especially, that can really impact on the care that people receive. Doctors who have implicit bias tend to minimize symptoms, especially in women and in women of color. They prescribe less medication for pain in an emergency room. The type of care delivered is worse. And if you even look at the dynamics between the doctor-patient interaction, the patient has less time to speak. They're listened to less. So it's very important that we look at ourselves first, especially if we're dealing with somebody from a different background than we are.
Annalise, lifestyle factors influenced by poverty includes diet, physical exercise, even exposure to air pollution are considerable risk factors for cancers as well as NCDs, non-communicable diseases. What are some of the obstacles impacting good health outcomes for communities and in the areas where you've worked specifically?
So I work in a poor rural state, Arkansas, and we're currently #1 in food insecurity. We also are 49th in terms of lung cancer mortality in the nation, and also in the top 2 for Black maternal mortality. I don't think that all of these issues are separate. It is all of these issues are combined by various factors. I think that we have a lot of, just to give a little background about Arkansas, Arkansas is also home to Walmart, which is one of the richest companies in the world. But at the same time, we also have a lot of disparities in various health metrics. How I think personally as a doctor to try to overcome that, I think one is actually working in these areas and then engaging with communities and to understand some of the barriers. So for us, I'm actually a neurosurgeon oncologist. So most of the time people come to me, they have late stage cancer. The most common type of brain tumor in adults is brain metastasis from cancer. So what I see is people at stage 4, very commonly they're diagnosed at stage 4 with a brain metastasis. So I'm seeing very late stage disease. And I would say that the way to try to address these disparities is actually by talking to people in the community and also trying to make sure that everyone has access. And so having kind of a hub and spoke model in terms of making sure that once you get your care at a large center, are you able to go back home and actually have some help in regards to what it takes to go on and survive cancer.
Teresa, in your role at Emory University, you oversee community-facing activities such as the recruitment of underserved populations to clinical trials and other efforts tackling cancer health disparities. What lessons have you learned that you can share with us?
Sure. So, like Annalise, I live in a state that is primarily rural outside of metro Atlanta. 75% of Georgia is rural. And so that creates a lot of problems when we're talking about clinical trials. We also have a very large minority ethnic minority population. And there is a assumption and misperception that people do not participate in clinical trials because of a history of mistrust or not believing things that are said to them. That really is not the case. The data show that people of color actually agree to be on clinical trials more often than their white counterparts, but there are a number of what tend to be structural barriers why those individuals do not participate. So as Helen mentioned about implicit bias, sometimes there is an assumption that if the patient lives at a distance or maybe has a lack of resources, perhaps that will be a less ideal candidate to go in the clinical trial, and maybe that person won't even be invited or told about the trial. But for those who are invited or asked and have an interest, now we come to these problems with structural barriers, transportation, lodging, out-of-pocket costs. So those are very important reasons why people are not able to participate and why there's a lack of really good representation. And the impetus to have representation on clinical trials is incredibly high for many reasons, but in large part because of generalizability of the findings. So not having that equity of representation is a serious problem for all of us.
Do you see, just to follow up on that, do you see health institutions making an effort to address some of these structural barriers that you described?
Yeah, so we actually have a task force to address those. And one of our strong partners is the American Cancer Society. We have a Hope Lodge that is very nearby where individuals who need to spend the night are able to get access there. But we also have lots of vouchers and other support for people who need transportation, sometimes help with childcare. So, but it does have to be intentional. It doesn't fall out of the sky. You have to really have a plan. And I think that was brought out earlier. You have to have a plan.
Timothy, the part of what I think is really interesting about this conversation is we often focus on lower income countries, but here we're talking about a high income country. And obviously, just because you're a high income country does not mean you do not deal with disparities, poverty and other issues. Can you speak to other countries that you've seen successfully address unequal access to cancer care? What do you think the US and maybe other high income countries can learn from other countries and their health systems?
Well, I mean, I live in Massachusetts. We have universal health coverage. Everybody is required by law to have health insurance. And yet we have incredible disparities. We have rates of cancer in some of our Boston neighborhoods that are as high as the worst places in, poorer parts of the U.S. So it's not just about money. It's not just about insurance. It's a multifactorial problem. So we have, for example, do a lot of work in Rwanda. They have a national health insurance plan. And so they, despite the fact that they're under-resourced, and they have put into place systems that allow for cancer services from the very primary part of care all the way through to regional hospitals, to major referral hospitals, to specialty cancer centers. And so again, a place like Rwanda, in some ways, even though they have very limited resources, does a lot better than we do in Massachusetts, even though we have, world famous institutions that can do the very cutting edge care. We don't have systems in the United States. We're piecemeal. We're, siloed in our healthcare. And again, not that Rwanda is perfect, but they've put together a system that leads from somebody seeing their primary care doc for a child wellness visit and figured out how to flow that person, if something is found, all the way to an oncology center. We don't do that. And so, again, not that solving the U.S. healthcare system is something that we probably have much control over, but those systems make all the difference. And if we look at what Rwanda and other places like it have done with much less resource, they've made things happen that we in the U.S. would struggle to achieve. And so that we can learn from that.
Yeah, definitely important lessons. We talked a bit about, it was mentioned, rural versus urban disparities. Helen, you work with many underserved communities, including inner city populations. What are some of the different access issues and disparities you see facing urban versus rural communities across the areas that you work in?
So my hospital is in an urban area. It's literally a left-hand turn and several blocks from where the shooting occurred in Buffalo, where 10 African Americans were targeted and shot by somebody out of town. So I'm right in that area where people should be close enough to the hospital that they can get access. But it depends on so many things. It depends not only on having insurance, but the quality of insurance, what the panel is of the providers. It depends on which neighborhood. I was sitting in the operating room one day waiting to operate on a lady who had cancer. She wasn't there. I called. It was the middle of the winter. Her street was in an area of town where they don't plow quickly. They get left till the end. I literally got in the SUV. I'd driven from 40 minutes away, drove, picked her up, brought her and her son to the hospital. It's all of these little things, as you were alluding to, that we don't normally think of that are incredible barriers to care. So being in an urban environment, at least there are bus routes that can sometimes get people to us. But I'm also involved with a group. We make street rounds. We go and we do screenings. We ask questions. We go with medical students trying to meet patients where they are. We try and involve trusted community advisors, whether that's a church or a barber shop or somewhere where there's people that they trust that can help engage them in doing screening and things of that nature. And we are not too far from rural areas, which is really, it's difficult to get people in from other towns, like a drive from a rural community outside of Buffalo, New York. Some people literally won't make it. They won't get the care that they need. So it's very challenging.
Another obstacle is often English not being a first language. Annalise, what will it take to raise awareness around cancer care prevention and treatment in diverse communities, including those for whom English is not a first language? If there are one or two lessons that you want the audience to walk away with and begin to lean into tomorrow, what would those be?
I think I'm going to just talk about a success story because I think talking about cancer disparities can be quite disheartening. So I want to talk about the HPV vaccination strategy that was implemented by Puerto Rico, and thinking about how HPV, as we know, can cause cancers, various types. Cervical cancers is what gets the most attention, but also can lead to head and neck cancer. And in 2018, Puerto Rico was the first, one of the first places to start to make it mandatory to get vaccinated in order to go to school. And this was after Hurricane Maria. So if you think about that, how did this happen? That now Puerto Rico is one of the top 5 places in the U.S. and its territories that has the highest rate of HPV vaccinations. And now that it's so many years later, we're going to probably start seeing the effects of how this lowers cancer rates. But it was a lot of things. First and foremost, it was health policy that before 2018, they rolled this out in 2017, the Department of Health there, and they had conversations with the community. They identified what were people hesitant about, and they were able to provide patient education that was informative. And then the other thing is the community engagement. So there was a woman who had diagnosis of cervical cancer at a young age. She was a mother of 3 children, and she went public with her story. She later died, but this galvanized a lot of community organizations to push for this vaccination to take place. And then another thing is about bias or thoughts that how can this happen in Puerto Rico, where you think of the history of how the government has done eugenics programs and mass sterilize huge populations of women But now, fast forward decades later, and the government is intervening to prevent cancer. And how can you get buy-in from a community that inherently distrusts the government for something better? So I think we can learn from that. A lot of things that come to mind are patient education, providing that in whatever language, people's native language, as well as thinking about how to synergize between public policy and community activism. So that's what comes to mind.
And are you, just to follow on that, are you confident Puerto Rico did such a good job of countering the misinformation about the vaccine? We obviously, it's quite a crisis if you think about it in terms of misinformation about vaccines. Are you confident that slowly after COVID-19, that some of that misinformation is being dispelled, or that there is this active effort like there was in Puerto Rico elsewhere in the country?
Yes, I think that they used more of a grassroots type of initiative, and they also had people that were relatable in terms of that woman who shared her story, and they used social media heavily, and then provided education in various sectors. So I think we can learn from that, because obviously that was 2018 when this was implemented, and then COVID happens 2020, and misinformation is really difficult to overcome, as we all have learned. But I think that, to me, what made that initiative successful was the grassroots, that it's people from your own community telling you this, someone that you trust. If you look at COVID vaccination in certain racial ethnic minority groups in America, such as the Black community or the Native American community, some of the same things when you think about how on reservations, for example, people said, I'm getting vaccinated because if I don't, my language is going to die out. Our culture is going to die. We have to shut down people having access to our reservations. We have to get vaccinated. And that was from those community members. So I think that can help dispel misinformation.
Let's stick to that subject a bit. Helen, if you could, Helen and Teresa, since we haven't gone to you in quite a while, how do you see that post COVID-19, some of this misinformation around vaccine hesitancy is being addressed, or do you think that we've kind of stagnated on the issue, or even increased now with the potentials of AI?
Yeah, it's interesting. I'm actually aware of call it an infodemic, really, because there's so much information out there, and having digital literacy and being able to discern what's factual versus what is fiction or hype is really, really difficult. And there are some new programs, AI programs, that are being developed to help the average person see what's truthful and what isn't truthful. But I agree, going to trusted community advisors, being in community with people, surrounded in their safe places with people that they trust, is a way to get the information out there. It's a jungle out there on the internet, and I think people are having a really difficult time getting the information that's accurate. And education is so key, as a gateway to cancer care and prevention.
Teresa, any thoughts on the subject?
Yes, it's really interesting about HPV. If we had better uptake of HPV, we could actually eliminate cancers. We could actually get rid of cancers, which you can't say about a lot of other cancers. In our state, we have 94% vaccination rates for diphtheria, tetanus, MMR, meningococcal. People get vaccinated, but they don't get vaccinated the same way. It's around 60% for HPV, because it's presented to the parents as differently. It's like, well, this is an option. You don't really have to. And I love the fact that Puerto Rico has said this is a requirement to go to school. That's why our rates are so high with these other vaccines. It doesn't make really any logical sense to say that parents will have their kids vaccinated for this panel of vaccines, but not HPV, because there's some degree of post-COVID mistrust that doesn't really kind of follow logically.
If I may, I think initially when the HPV vaccine was rolled out, there was this element of describing it as preventing STDs as opposed to preventing cancer. And your point is well taken. We have the ability to to prevent several of the cancers that are increasing in incidence: colorectal cancer, cervical cancer, these head and neck cancers, and especially with HP, where it's just not happening because there's still a degree of maybe stigma attached to it, and this idea that it's optional, which it shouldn't be.
Well, and if I can just add, Annalise's point is really important, but it's important to note that one size doesn't fit all. So what worked in Puerto Rico wouldn't work in Massachusetts necessarily, maybe some of the concepts. In China, they have very high rates of HPV and HBV vaccination, but they just forced everybody to have it. And they didn't, there wasn't a question of, do you want this or not? You just got it. And that wouldn't work here, right? So I think it's really important to understand the local context, very local context in which these things are being applied. And your point about the early view that this isn't, like in Australia, they said this is an anti-cancer vaccine. We didn't do that. We didn't get ahead of it in time. So and now we're doing catch up to try to get rid of those poor messages that we started with, because there was no plan when we started.
And I think that's an excellent point, that, it's not a model that can just be instantly replicated. But, we talked about Puerto Rico, talked about Rwanda. Teresa, Helen, I'm wondering if there are any examples where there are some lessons that could be incorporated, maybe from different regions in the U.S., another high-income country, or a lower-income country. Are there anything, success stories that you see that maybe here in the U.S., in terms of disparities, we could adopt or we could learn from?
I would say in terms of clinical trials, it's really important to engage all communities to participate so that the results are broadly applicable. And I think going back to some of the things we've discussed already, there are several studies that document that personalizing recruitment, having patient navigators, people from within their own communities, really helps to engage people from all different communities, races, et cetera, so that it's definitely proven it makes a big difference in terms of recruiting to clinical trials. And I think that's critically important for developing new interventions.
I think screening is an area where we can do better and have done better in some cases in reducing those disparities. There's a lot of states that have breast and cervical screening programs as well as follow-up programs. We have done a lot in the state of Georgia in rural areas for colorectal screening, but I want to just make a point that was sort of made with the chronic kidney disease. Screen is really important. Follow-up is really important. And I love the motto of Devex because it's do good, do it well. And so if you're going to screen, I think the most important thing is do you have a plan to follow up when an abnormality is found, to do diagnosis, and to do treatment? Because what's been really trendy, and they think that this is the way of sort of reducing disparities, are these mobile screening things that go out and they do prostate screening or breast screening or lung screening. But then when the person has an abnormality, there is no plan for what that person is going to do. And as was brought out, either they don't have insurance or they're underinsured, or they can't get to where they need to go. And that is an incredible disservice, and that only exacerbates disparities. So if we're going to do that, we need to do it well. And I think there are many places that are doing it well.
Well said.
There's definitely a lot of organizations, like you said, that will help with the follow-up, but it does seem like a patchwork. Do you see like a unified effort to, like you said, after screening, after mobile screening, if you get a positive diagnosis, what do you do next in terms of insurance, in terms of seeing the next doctor? Do you see there's a good, solid effort across the country, or would you say that it needs to be more holistic?
Well, I'm about ready to move to Massachusetts because I live in one of the few states, Georgia, that has still not expanded Medicaid. And so we deal with the problems that could be addressed on a health policy issue every single day. And screening and access are rampant because of that issue. And I admire states that have done so much better, even without extensive resources. But health policy is where the rubber really hits the road. And I think we spend so much time with other things that we don't always recognize the importance of that.
The people making the policy have good insurance, and so it doesn't become a priority, I think.
That's an excellent point. It's a very valid point. Before we get into Q&A, I just wanted to briefly follow up. Is there a final call to action that you want to see, whether it's at UNGA or just in general in the weeks and months to come?
I guess what I would say is I really believe in being aware about the unconscious bias, implicit bias. There are several great tools, one put out by Harvard as it happens, where you can go and take it online. It's free and it's really educational. And just again, to really engage everybody in clinical trials, it really matters a lot.
Teresa?
I think clinical trials are incredibly important and the investment that's been made to advance treatments. But I would just say that prevention and screening, while they're not as sexy, they cost a whole lot less and they can actually do a whole lot more. And it really gets back to an ounce of prevention is worth millions of dollars of trying to treat someone.
I think the theme I've been hearing is that of being more holistic and a little less siloed with what how we're thinking about things. So policymakers need good evidence. So scientists, researchers need to inform policymakers better than we do. There need to be better health systems. That's policy, to get the flow of information from a patient into a care pathway. And, I was here earlier, I was listening to some of the kidney studies and the cardiovascular and metabolic work. All the things that they said were the things we say too. And so I think we're also very siloed within our disciplines. What if we had a great blood test that looked for protein in the urine and cancer biomarkers and, fill in the blank? Can we be a little less siloed? Can we communicate better across sectors?
Absolutely. Annalise?
I think the main thing is synergy, that we are, again, siloed. And there's so many different sectors. We talked about health policy, and we talk about workforce and, in terms of healthcare provider workforce. And then there's the other side in regards to research and relationships with big pharma, et cetera. But we definitely just need to understand how we can synergize between all of those different sectors to promote change.
All right, so we have some time for audience Q&A. Richard has our microphone. If you had a question, yes, right here. If you could state your name and affiliation, that would be great.
Okay, hi, hello. This is really powerful. My name is Bukola Shunuga. I'm a co-founder and CEO of Beyond Remittance Group. That's an international agency, but here in New York City, we do a lot of community work in the African community. I'm a Nigerian American. And I wish the candidates running for election could be here. Because in terms of disinformation and misinformation, the media tend to sort of distill information and tell us what we want to hear. This is the real issue. It's not about economy. So that's one observation. Secondly, when we talk about education, it's key. And also in terms of CRT, critical race theory, where information is being controlled about what we share with students and so on. My specific question is that, is any of you experiencing some sort of a barrier in terms of information sharing? When we talk about issues like this, it's not just at a higher level of education. What about primary education in the communities, right? And talk about policymakers. They're not here in this audience. So education in terms of policy and how we get information, accurate information across the community is actually the most important thing. So I don't know if you have any thoughts on that.
Education.
Oh, I guess I will. I think I live in a red state, so I definitely encounter some of these issues. For example, DEI has been eliminated at all state universities in the state. So I think we call it career pathways now instead of DEI, and you're not allowed to explicitly have an event for a certain group. So that gets a little bit interesting. We definitely don't want to exclude anyone, but we also need to be aware that different groups have various priorities that are intrinsic to that group. So it can be very much like a minefield, but I do think that what I've seen personally is that during these times of, I guess, oversight by others to try to, I guess, prevent people from uniting. I would say that in these times of strife, that you see more of advocacy and community groups forming on their own, and I think that's kind of what I have seen, that people want to provide education or prevent some of the things that they see happening on these state and national levels. And so I think that it's basically maybe going underground, but these groups are developing and becoming stronger in a strange way as a response to counter some of the things that we're seeing.
Any other thoughts in terms of early education or politics, for that matter? I feel like we're in DC talking about politics.
I would just say that I think they're dealing with breast cancer, which is my field. It seems to be a disease site which women have really banded together across state lines, across cities, across gender, or not gender, but I'm sorry, race, to unite nationally. And I think what you alluded to, this patchwork effect, is really one of the biggest barriers to delivering education and care and preventative care. So the more advocacy there is and people generated movement, I think that's really going to be key to getting the education.
And just to emphasize, to me, it's advocacy into policy. So the advocates are incredibly powerful in getting things done, but it needs to be done in an evidence-based way. So there needs to be science, there needs to be data. The advocates, advocates need to talk to scientists, and the advocates and the scientists need to talk to the policymakers. And that happens. There's a lot of that, but there's also, it's a little bit chaotic, not siloed. There's 100 advocacy groups going up to Capitol Hill. And there's, unless you talk about things like Sea Change or the American Cancer Society, where they're trying to work with one voice. But it's very difficult to achieve that when it's somewhat siloed, somewhat unplanned, and the policymakers don't have a clear picture of what's really needed sometimes.
Well, for breast cancer specifically, they're now paying for screening on a regular basis. Legally, we're required to give them the results of that day so that they know what's happening. So it does make a big difference.
Yes, we have another question in the front.
Thank you. Monica Chowdhury from Adira. I actually want to ask the flip question. I was really moved by your comment that, we have lack of continuum of care, and the departments of health and Medicaid is one area where you actually do have the opportunity to really have continuity of care with coverage, etc. So can anybody share a best practice of where a state department of health or a Medicaid population has seen a success story? We work very closely on the WIC program, and that's a beautiful program where there's a lot of commitment to enrollment and then follow through. Is there anything like that in breast cancer? Because my concern is when private sector gets involved and advocacy groups get involved, there's a lot of fragmentation, exactly what you said. So my question is about public sector success stories. Thank you.
So the one that I know best is the VA system. And the VA is maligned a lot, but undeservedly. They're a great system. And we've done a lot of research in the VA, and we found things like if you directly compare people that get care in the VA compared to free living people outside the VA system, they do better in the VA. And that's not, even if you match for all the stuff that people vary in. And part of that is because VA has systems. There are care pathways, there are plans. If you have this, then you get that, within guidelines. And when you're out in the free living community, you get what you encounter. And if you have really good health care, if you're me and I'm at Dana-Farber and I can go to all the Harvard hospitals, I'll get whatever the world can offer. But most people aren't like me. In the VA, people are more aligned in the kind of access they have and what's available. And so I think that there's a really good example in the VA system that shows us that quality of care is possible in a systematic way by the government in this case.
Another system that comes to mind is California. So they have a cancer patient bill of rights, and they do have patients that have the state insurance, the government-based state insurance, are allowed for certain diagnoses to go to a larger cancer center if it's not available close to home. So they have that possibility of going to a larger, say, comprehensive cancer center.
The VA is both excellent examples. I think VA is kind of one of those agencies that often gets falls under the radar, if you will.
Well,
I think
or gets maligned when it's really not deserved. I
Yeah.
think people really should value the VA. It's an amazing system.
Mm-hmm. We have time, I think, for one more question. And
We have one in the back as well.
One in the back, Richard. Yes, thanks. Couldn't see.
Yeah, hi. Thank you very much. My name is Shubha. I'm from India. I would like to ask, what is your role in working with the medical associations here in informing from your research for updating the treatments, which will in turn inform the policymakers in revising the treatment guidelines, which will inform the insurance for treatment, because there's so much of development that's going on, and then we are at very nascent stages in developing countries, and this is a big issue for us. But our countries and our states are expanding insurance companies, but this is a big area for big problem for us. The second question is from the doctor from Arkansas. So do you work with Walmart? Did you ask for funding from Walmart for your work? Thank you.
We'll start with.
I'll just answer no, I do not work for Walmart or with Walmart, but I do go to Walmart sometimes. I have to admit, but I'm in Arkansas, so I apologize for that.
And so the first part of the question was, do you work with also medical associations in your jobs?
I guess, yeah. So I think I happen to be in the oncology field like everyone else. So I think there's large associations. Like for me, one of the places that or organizations I've worked with, partnered with, is the American Association of Cancer Research. And there's a disparities report, and I was lucky enough to be in that steering committee. And so it's available online, and you can look at it's basically a state of the union of current cancer disparities in the US. And it's covers a wide range of topics, but there's other organizations as well, such as ACS, ASCO, and then within neurosurgery, I do partner with other organizations.
So there are national organizations. There's also state level, like we have a Georgia Society of Clinical Oncology, which is a state version of ASCO. And so we work with all of those in terms of providing data and evidence. And one of, I think, a success story about from a state level, because all things that are government are not bad, including the VA, is we have a very representative comprehensive cancer control plan for the state, which includes government, academia, advocacy, community organizations, stakeholders. So we have a lot of people working together to try to develop, what should be the plan, what should be done, how do we impact guidelines and bring that all together. So I think there's many opportunities, and I think many of us work with those opportunities.
The other thing that the NCCN is a national organization that puts out guidelines that all of the partner cancer institutes partake in. So directly to your question, we do all participate on an annual basis, reviewing the data, getting together, talking about it, and giving the next year's recommendations. And it's all very evidence-based with different levels of evidence. So that does happen in a very formalized way.
Great. Well, we are at time, so please join me in thanking our panelists today. And I'd like to welcome back to the stage my colleague, Richard.
Thank you very much. And to our panelists, thank you. If you'd like to take your seats, please. That was a fantastic discussion. A big round of applause. Thank you very much. Thanks very much, Anna. Now, to help us reflect and wrap up our conversation this evening, I'd like to welcome back to the stage Josette Bermudo, Executive Director, U.S. Health Equity at MSD. Josette, if you'd like to join me up on the stage. Josette? Josette, you're on. a reluctant closing speaker. Josette, I just wanted to ask what messages stood out to you in that panel session. How would you tie all of the various threads together? What would you like our audience here in New York and online watching around the world to really take away with them? And what's your main call to action here at UNGA 79 this week in New York?
Richard, that was like 5 questions rolled into one.
and I'm also kind of leading the witness here as well. But Josette, over to you. The floor is yours.
Thank you, Richard. First of all, just thank you to the illustrious panel. The perspectives, the points of views, the nuggets. I think I wrote down so much. But I think there are a lot of critical threads that were interwoven right throughout this discussion. Such a big emphasis on data. Taking that data-driven approach. But what I liked about the discussion on data is we have so much data, but are we pulling the right insights from the data? And when we think about cancer inequities, it looks different depending on the stage of the patient journey. So the inequities will look different in screening versus for early detection versus who's getting on therapy at a timely fashion. And so are we leveraging the data to know where the disparities truly exist so that we're anchoring our interventions in a smart and right way? And when I think about those interventions, I really appreciated all the points around making sure that we are bringing community. So Nefertari, thank you for reminding us that we could sit in our ivory towers and come up with the best solutions and interventions. But if we're not bringing the community and patients that are most impacted where we are seeing those disparities, then quite frankly, we may just hit things off on the wrong foot. So making sure that we really have the communities co-creating at the table. Measurement was another very critical piece as well. And I would say patient navigation, being able to really support patients through the care pathway, not just focusing on screening. I really appreciated your point, Dr. Gillespie, around screening is important. That's a very important, critical step that we all have to contribute and invest around. But once we now have a diagnosis, potentially, what comes next? And so really making sure we can support patients through that journey. And then the last thing I will say is around information, patient activation, democratization of information. We talked a lot about misinformation. So making sure that information is at the fingertips and being shared in culturally sensitive and appropriate ways to the variety of communities that we aim to reach. So those were the points that sat and resonated with me. Hopefully those are the points that resonated with you. But thank you all for those that are listening virtually. Thank you all for those that are here. I hope you all are walking away with some very helpful insights.
Many thanks, Josette, for that analysis and neatly wrapping the session. To you, to MSD, to the American Cancer Society, thank you very much for your partnership and helping us at Devex to power our journalism up on the UNGA 79 stage this week. A big thank you to our speakers and to our interviewers, to our in-person audience and those watching online around the world. Stay tuned for our next event this evening from 7 p.m. Eastern Time. This is in partnership with the African Development Bank and UNHCR, where we'll hear from AFDP President Dr. Adesina, United Nations High Commissioner for Refugees Filippo Grandi, and more. For a conversation on how humanitarian and development finance can foster peace and drive resilience in Africa. And from tomorrow, it's starting at 1 o'clock Eastern Time. I'd invite you to join us again for the final day of our Devex at UNGA 79 Summit. Meantime, many thanks to everyone. Thanks for joining, and all the best from all the team at Devex. Thank you very much.